Hello, everyone. Thank you. It takes a minute to figure out how to share my screen. I mean, not to figure out, but actually share my screen. I'm Gwen Darien, and I am the Executive Vice President for Patient Advocacy Engagement and also Education at the Patient Advocate Foundation and the National Patient Advocate Foundation. I'm also a three-time cancer survivor. I started working in cancer advocacy after my first diagnosis of cancer, which was almost 30 years ago. So I was asked to give some patient perspectives, and I will say these are patient perspectives. This is not the patient perspective on the EHR and what the EHR meant to us from a patient lens. And for what I think of it is that it can either be a facilitator of trust, which is what I believe all of our goal is to make it a facilitator of trust, communication, and better outcomes, or it can be a mediator of communication or in a barrier. So I wanted to talk a little bit about the EHR and the patient-physician relationship or the patient-healthcare relationship. Whoops. There we go, sorry. So I'll start with just a personal story. This is a story that is not unique to me. It's a story that I've heard from many of my friends and colleagues. I'm in a cohort of young adult cancer survivors who now have gotten second and third primary cancers, and so I will say I didn't see it coming. It was, and I mean that both literally and then how I thought of having a second cancer. So one of the most important things I think for and one of the things we've talked about a lot is that you have to see someone, and you have to see someone as a person. And if you're looking at a computer screen, you often don't see somebody as a person. And a lot of the many of the first times that a patient interacts with an EHR and their physician is through their diagnosis and through their diagnosis story. So this is a story of my second cancer, which was breast cancer. I couldn't see the door in the exam room, which was L-shaped. I could only hear a knock and then her voice reading the EHR. "I'm sorry, it's breast cancer," the surgeon said. I did not see it coming. I didn't see it coming in any way that I was prepared for, and I didn't actually see it coming, and she didn't see me. So context is everything. You have to see the whole patient, and you have to use, I think that we have to be reminded that the EHR is a tool, as Drs. Levy and Schulman said, for communication and for patient engagement. But its some of the original uses as a billing facilitator, and it were not have interrupted that. Have interrupted that potential and many patients see it in that perspective. So in the age of COVID, telehealth is a home visit. It's something that we've talked about in a number of different workshops, but it is also, and that can be good and that can also be bad. I remember my father's a retired internist, and when I was a little girl, I used to go, he would do his house calls and I would go with him, and I'd sit in the car and I'd be so proud of him. And he'd visit all of his patients in their home environment. And that's what telehealth can do, but it can also be a barrier because some people don't have the ability to find privacy, to find a place and a space to have a home visit. So I know that Dr. Hughes-Helbert is going to talk about some of that later. Unequal treatment, and out of this, unequal access and treatment persists despite or because of the medium of healthcare encounters. A recent story for me was not with an EHR, but it was with a workshop that we were doing. And one of the people who was in the workshop had, because of the pandemic, she lived in a small house. Her daughter was home from school, and she actually had to do her panel from her car, and she had to call in from her car because she had no place that gave her any privacy and no place that was safe. And it's the same thing that happens with people in their work environments if they can't take things off, if they live in an environment where there is not much privacy and there are lots of people in the house. Patient portals, as Larry Schulman mentioned, there's the good, the bad, and the challenging. And some of the challenging is the information that this kind of lack of both the interpretation of the information, but also the ability to access the information, whether you have what your access is, whether you have broadband access, whether you have your own computer or smartphone that you can log into. One of the women that I work with very closely, a patient advocate, is in West Virginia, and her internet and her telephone go off all the time, and so we need to always consider that. So I would say one of my favorite cliches is it's not what you say, it's what you do. There's a lot of saying these days, but we have to make sure that there's the attendant doing. But from the perspective of an EHR and perspective of patient portal and communication, it's not what you say, it's what you write, and the transparency and the trust around that. And most patients I know who've gotten hold of who have seen their medical records are really, are often very disturbed by the mismatch between the conversation with their healthcare provider and the medical notes. I will say I experienced this as my first diagnosis, where when I took my giant file of medical records, because that was 25 years ago, everything that I read in the records was very different than what the physician had told me, oncologist had told me, including and most disturbing for a cancer patient, the possibility of recurrence. So words matter, observations endure, and bias persists. There has been a lot of research recently about how bias persists, how biased language is in medical records, and we know that it doesn't, as Larry Shulman said, that we add to it. So the bias persists as it goes from one healthcare provider to another healthcare provider, and the way that patients are characterized, the way that how they talk about their why they are at this visit changes, and the racial and ethnic bias in terms of language is an unacceptable and egregious, and it must be addressed. When you think about what you write in your in the EHR, think about your patients or their family members as the readers. Think about how loaded language. I mean, I think as a cancer patient and a cancer advocate and healthcare advocate, one of the words that makes the hair on the back of my neck stand up is non-compliance and non-adherence. So you see all the time that a patient was either non-compliant or non-adherent, but do you ever see the question why? What is preventing that? What is preventing somebody from fulfilling the care plan that they created with their healthcare provider? And it is not generally a patient reason that the patient is not compliant or does not want to comply, which is also an incredibly top-down and very loaded and judgmental language. So one of the things that, so my first experience with the EHR when I was diagnosed with breast cancer was, it was incredibly difficult and incredibly upsetting, as you could imagine. But then later experiences, I chose a different practice to go to for that, in a different hospital system to go for treatment, was I think an example of the best use of the EHR, the computer, and that was in terms of sharing a screen. My breast oncologist and I would look at the screen together. It's a way of empowering patients and improving communications. We would look things up together. She would share the screen. And as one colleague, Dr. Maria El-Qureshi, talked about in an earlier paper, you create a triangle of trust. So there's the patient or patient and family members, the clinician, and the computer screen, and that triangle creates trust. So if we look at this, the goal is to have patient-centered EHR communication, and we use the EHR to build and sustain bidirectional trust. So this supports patient empowerment It also supports self-advocacy. And as most of us who've been patients, which is everybody, often our self-advocacy skills fly out the window when we've received a serious diagnosis of illness. And this is one way of bringing back the patient empowerment and the self-advocacy. So the EHR, so in conclusion, it can be a tool for health and a facilitator for healing relationships. But we also have to be mindful of the screen as mediator and how we look at each other. We have to be mindful of seeing the whole patient, not just seeing them through the computer screen, but also considering all the factors of their life, of their diagnosis, of their quality of life. Words matter. It's very, people don't forget words. It's seared into my memory. Some of the words that my oncologist said, and also my primary care physician, when I was diagnosed with non-Hodgkin's lymphoma almost 35 years ago. Almost 30 years ago. I hear those words. They repeat to me, and sometimes they really catch me up. You have to consider the patient and the family as readers. I know that earlier on we didn't, in my dad's giant chart room, I don't think that many of his patients saw their charts, but we do see our charts. We do see more now. We see it more from our patient portals, but we also, as both Mia Levy and Larry Shulman mentioned, they aren't particularly portable. So the fax machine of old is still in use. If our goal, and I think my goal and most patient advocates' goal, and also healthcare providers' goal, is to have a patient-centered EHR communication as the foundation for patient empowerment, trust building, healing relationships, and outcomes that matter. And that's what we should really strive for, is as we talk about patient-centered healthcare, we also have to think that patient-centered EHR communications can be a critical tool and a critical way of building that patient empowerment, trust, and relationships. Thank you, and I look forward to the panel.